Delighted to have this special lecture. We have a very special guest today, Professor Hamm, who is the chair of radiology at University of Berlin, Charite Hospital. He's actually someone who has done his entire career in Berlin and very well known for his contributions in prostate MR imaging. He has published over 600 papers, original papers, 11 books, many book chapters, was invited to give lectures more than 500 times, including the RSNA and the European Congress of Radiology. I believe you are the president of the European Society of Radiology. So we are really honored to have Professor Hamm, and obviously he didn't come here for no reason. He also has a very good reason to come to Yale because his son is actually in medical school doing a rotation in the emergency, in our own emergency department here at Yale. So Professor Hamm, we're delighted to have you. Thank you very much.
Thank you, Dr. Gershwin, for this kind introduction, and welcome to all of you here in this room and on the broadcast. And this is my disclosure, and I was asked to give a talk on imaging of the prostate, and I added the subtitle, Challenges and Opportunities. And in the first edition of Lancet, it was mentioned that prostate cancer is a very rare disease. However, nowadays, we've learned that prostate cancer is a major public health problem. And right at the beginning, you will recognize that this presentation is a little bit like a yin and yang story. So let us start with the glory and disaster of PSA. Per Anders Abrahamsson, the president of the European Society of Urology, said, PSA screening will come, and the best screening age is between 45 and 65 years. However, Richard Albrin, who discovered PSA about 40 years ago, he said, it should never be used as a screening tool for all men. And in the meantime, he has written a book entitled How Big Medicine Hijacked the PSA Test and Caused a Public Health Disaster. So there are two large randomized trials who tested whether screening reduces prostate cancer mortality. While the US trial reported no benefit, the European trial noted significant reduction in mortality, and the number to detect to save one life fell from 48 to 27, which is a good result. However, let us have a closer look to the US trial. And concerning the data from the surveillance, epidemiology, and end result registry, yes, we could have seen that there is an increase in incidence, and then there is a continuous decrease in incidence of prostate cancer. However, we should be aware that during that time, there was an increase in PSA screening, and based on published data, thereafter there was a decrease on PSA screening. And during the preparation of this talk, I came across a very interesting article published in the New England Journal entitled Lessons in Cancer Dynamics, and the authors analyzed the incidence of cancer that was metastatic at the first presentation. And surprisingly, even with the introduction of mammography screening, there was no significant reduction of metastatic breast cancer at the first presentation. However, after the introduction of PSA screening, there was a significant reduction of metastatic prostatic cancer. So, and I'm fearing if the PSA screening is going down, in the future we will be awaiting an increase of metastatic prostatic cancer. However, early detection of prostate cancer by PSA screening is controversial, and these are the controversies: overdiagnosis, underdiagnosis, misdiagnosis, misclassification of risk, overtreatment, and undertreatment. And yes, you can see this is really a yin and yang story. And this is the prevalence. Prostate cancer is very frequent. Let's have a look to this autopsy study. For example, in the age between 50 and 60 years, 55% of men have a prostate cancer on the histologic level. And Guido Sauter, he's the pathologist from the world's largest prostatectomy center in Hamburg. He analyzed the prostate of patient with a normal prostate who received a radical cystectomy and prostatectomy because of bladder cancer. And look at this, 65% prostate cancer at 65, 76 at this age. Roughly, very roughly, we can say on a histological level, at the age of 50% of men have prostate cancer, 60, 60, 70, 70, and at the age of 80% of men have prostate cancer on the histologic level. And the big challenge for the medical community is which prostate cancer should be detected and what cancer should be treated and which is the leave me alone lesion. So nowadays, prostate cancer is detected by the digital rectal examination. It is overlooked in the area of PSA. However, it's important because there are also non-PSA secreting tumors. And of course, we have the PSA, which is a secreted enzyme, but it's not specific for prostate cancer because it can be elevated in prostatitis and in BPH as well. And these are our problems. The PSA is a non-specific marker. It's very sensitive in patients with prostate cancer, but it does not help to exclude prostate cancer, whereas the digital rectal examination is not sensitive. However, if you feel something, like in this digital rectal examination, and if there is a positive finding, usually it's too late. So therefore, the standard of care is the 12-core needle biopsy, left and right prostate, medial, apical, mid, and base. However, these truss-guided biopsies give us a limited survey of the prostate. These biopsies are unguided and blind, and lesions are missed, skimmed, or undersampled. And what is the role of MR imaging? Let us have a look to these 4 different patients as it is shown on every daily clinical basis. So this is a patient, 71-year-old, PSA around 4, and the patient was a little bit in doubt, should he have biopsy or not? So we performed an MR. T2 looks quite normal. However, the diffusion-weighted imaging shows a very small lesion in the ventral part of the prostate. It was a Gleason 3+3. This patient is on active surveillance since 2 years now. This patient, 65-year-old, elevated PSA of 13. However, he has a huge BPH. This is just the peripheral zone. No prostate cancer, no reason for biopsy. And this patient, 67-year-old, PSA of 7, a little bit enlarged prostate. He had one truss-guided biopsy. The truss-guided biopsy was negative. The PSA is still elevating, and therefore we performed an MR. This is a prolapse BPH nodule. Don't care about this, but there is a small cancer, Gleason 3+4. Patient got a prostatectomy. However, this patient is fine. Young patient, small prostate, normal PSA, but this patient just want to have a checkup examination. Oops, big prostate cancer, significant prostate cancer candidate for radical prostatectomy. So today, MR imaging is a problem-solving modality. And in my presentation, I would like to briefly mention 5 different aspects concerning imaging: the detection of prostate cancer and the assessment of aggressiveness, staging of cancer, image-guided biopsy, MRI in active surveillance, and focal therapy, and finally, just briefly mention some future aspects. Multiparametric MRI significantly improved the detection of prostate cancer, and especially the diffusion-weighted imaging, which helps us to make an assessment of the aggressiveness, since we can be used for the differentiation of normal prostatic tissue and low-grade prostate cancer versus intermediate or high-grade prostate cancer. How does this work in the prostate? I would like to show it in this histologic specimen. This is prostate cancer with Gleason 3 components and Gleason 4 components. And when I'm asking you in which part of the tumor the diffusion, the movement of the molecules is more restricted, it's for sure in the Gleason 4 part of the prostate cancer. And therefore you can translate the diffusion-weighted imaging significantly improves the assessment of aggressiveness, as it is the case in this patient. 49-year-old patient with a continuous increasing PSA. This patient had 2 negative truss-guided biopsies, and we see a lesion in the mid-gland of the peripheral zone, and we see a small lesion in the apex of the prostate. Having looked to the diffusion-weighted imaging, we see that at this area, there is no diffusion restriction, whereas a diffusion restriction of this small lesion. This was the prostate cancer. And when you see these images, especially the diffusion-weighted imaging, you may think that we in Germany are using very old-fashioned MR sequences or machines, but please believe me, this is the difficulties with the different softwares of my Windows laptop and the Macintosh. So don't worry, please believe that these are much more high spatial resolution images in real life. This is another patient, 63-year-old, PSA of 9, 1 truss negative guided biopsy, and this patient has 3 different lesions. We have low sick intensity peripheral zone on the right-hand side. This might be chronic prostatitis or diffuse Gleason 3+3. We have another lesion here and a lesion there. What is the most aggressive part? What is the most aggressive tumor of the prostate? And adding diffusion-weighted imaging is very clear that is the lesion in the ventral part of the prostate, which is shown to be the most aggressive prostate cancer. This was a Gleason 4+4 prostate cancer. And therefore, we should not only see the lesions in the prostate, we should also identify which one is the most aggressive one, which is the dominant intraprostatic lesion. And in 2012, the European Society of Urogenital Radiology created the PIRATES version 1 and suggested the standard protocol for multiparametric MRI. And this is how we do it. We use a pelvic body phase area coil for high spatial resolution. We don't use the endorectal coil at 3 Tesla. Sometimes we're using it at 1.5 Tesla. Antiperistaltic drugs are suggested to avoid any motion artifacts. And then the T2-weighted sequence should be used in 2 different planes. The diffusion-weighted imaging using at least 3 B values, for example, 0, 100, and 800, and you may measure a high B value or calculate a high B value, and then you add a dynamic contrast-enhanced MRI with high spatial resolution or timely resolution. However, concerning guidelines, there are 2 different options. One option is to follow the guidelines very strictly, and the other option is to adjust your imaging protocol according to your preference. And Alexander Bauer from our department has performed a study with 55 patients and 130 guided biopsies in the prostate, about 50% in the peripheral zone, 50% in the transitional zone. And to make a long story short, he correlated the sequences, which is the most reliable sequence in assessing the PIRATES score, no cancer or high suspicious of cancer. In the peripheral zone, it has been shown that it is the diffusion-weighted imaging, as it is shown in this case. On the T2-weighted imaging, you see a lot of lesions in the peripheral zone. However, on the diffusion-weighted imaging, you see that these are the 2 most aggressive tumor parts of prostate cancer. Whereas in the transitional zone, it is the morphological T2-weighted sequence, as in this case. On the diffusion-weighted imaging, you may think that this looks like prostate cancer. However, looking at the T2-weighted imaging, you see a round lesion, heterogeneous signal intensity encapsulated, typical finding of stromal hyperplasia. So this is not a prostate cancer. And if we add all sequences together, there is no improvement in the assessment of PIRATES in the peripheral zone as well as in the transitional zone. And this has been included now in the PIRATES version 2, which was agreed between the European Society of Urogenital Radiology, the ACR, and the ADMETEC. And I highly suggest to have a look to the guidelines which is published in the internet. Usually we see what we believe what we see, but what do we see? Sometimes when we have patients which are a little bit on doubt, then we go to pathology and read the cases together with the pathologist on the microscope. For sure, This is a prostate cancer in the apex, shown on T2 and the diffusion-weighted imaging. And this was a peripheral zone prostate cancer, Gleason 3+4. And exactly in this area, there was a small prostate cancer, 4 millimeter in size, Gleason 3+3. And this should remain us on two things. First, prostate cancer is multifocal in about 80% of the cases, and usually we don't see every lesion. And it has been shown that multiparametric MRI underestimates both tumor volume and tumor burden. And finally, the authors suggested that we should check for the greatest volume from any of the sequence. Coming back to the question, what are the lesions which we frequently miss? And there are two interesting publications, and in summary, we can say these are the small lesions, smaller than 1 centimeter in size, the low-grade cancer, for example, Gleason 6 versus Gleason 7, and the satellite versus the index lesion. And therefore, we can say concerning the detection of prostate cancer, we should be able to detect the more aggressive tumors and the bigger ones. Usually these are the significant cancers, but we should be aware that we are missing the low-grade cancers and the small tumors, and hopefully these are the non-significant cancers. To get this aim, we have to improve our standards. Let's have a look to this case. Does this patient has a prostate cancer? Maybe in the morning of a fresh coffee you say, yes, there might be a lesion on the left-hand side, but in the afternoon, no lesion, next case. But this is exactly the same patient. 3 weeks later, because he wanted to have a focused therapy in our department, and same patient, let's say 3 weeks later, same examination at the 3 Tesla Siemens magnet. And you see there's big difference between the sequences. And Heinz-Peter Schlemmer at the ECR this year mentioned that multiparametric MRI at present, it's more a multivariable MRI. So we have to work on our own standards. I've briefly mentioned the Pirates version 2, and I don't want to go into details. And Müller-Lisse has performed an online survey among German radiologists concerning multiparametric MRI. The good news is that 90% use at least one function sequence, mainly diffusion-weighted imaging. This is not that bad. However, the second line is really bad. Less than 20% of the radiologists offer a structured reporting. That means, as radiologists, there is no need to lean back and to relax. There is still room for improvement. Now, let me go to staging of the prostate. In the past, there were a lot of publications concerning diagnostic criteria. And these are the criteria like irregular capsular bulge, obliteration of the rectoprostatic angle, thickening of the neurovascular bundle, and many more. However, let's have a closer look to these publications concerning the sensitivity in extracapsular extension. It's between 26 and 100%. And now let's have a look to the specificity. Excluding extracapsular extension, it's between 0 and 100%. I think this is not very convincing. So, and therefore, the European Society of Radiology described a score to the most important criteria concerning extracapsular extension, like capsular abutment, not a strong core, bulge of the capsule, stronger core, or measurable extraprostatic disease, like this case, a strong core. But how should we deal with this lesion? Capsular abutment doesn't look like extracapsular extension. So is this extracapsular extension or not? In our report, we say it might be microscopic extracapsular extension. But we should include more the clinical risk, according to DeAmico. DeAmico clinical risk include the PSA level, the Gleason score based on trust-guided biopsy, and the clinical examination. In patients who have low-risk disease, the prevalence of extracapsular extension is small, only 25%. And the surgical strategy is to have a nerve-sparing surgery. And therefore, for example, in this case, yes, there is capsular abutment, but we should use strong criteria. We should not overcall this criteria to have a nerve-sparing surgery. However, if we see extracapsular extension, of course, we should name it. In the intermediate risk disease, the prevalence of extracapsular extension is 58%. Let's say if it's 50-50. And the surgical strategy is not only to have nerve-sparing surgery, it's to have negative margins. And so, for example, how should we deal with this case again? And it is the length of the abutment of the capsule. If the length is less than 10 millimeter, usually there is no extracapsular extension. And if it's, for example, 20 millimeters, there is 60% of extracapsular extension. So we should use less strict criteria to have the option to have a negative margin. And it has been shown if there is good communication between radiology and urology with marking where the lesion is, because even if you have an open surgery or robot-assisted surgery, the urologist does not see the extracapsular extension if it's microscopic. If you have a marking, and then the urologist may decide to have an intraoperative frozen section and then extend his resection area, and it has been shown that multiparametric MRI reduces the rate of positive surgical margins. Whereas in patients with a high-risk disease, the prevalence of extracapsular extension is high as usual, and the surgical strategy, if undertaken, is to have negative margins. So, for example, in this patient, there is bulging of the prostate. It indicates extracapsular extension, but with an extended resection, this might be resected with negative margins. However, we should also focus on extensive extracapsular extension or semivesical invasion to preclude surgical procedures with positive margins. So this is the local staging. What's about the nodal staging and the distal metastasis? And we can translate N and M into nuclear medicine, because there is a perfect synergy between morphology and molecular imaging by using PSM, PET-CT, or PET-MR. PSMA is a prostate-specific membrane antigen, which is linked to the tracer, in this case 68 gallium, which is a very sensitive marker, and this can be used for diagnostic purposes and with another tracer also for therapeutic purposes. Let's have a look to this patient. This patient had radical prostatectomy and an increase in PSA up to 4.1. And when we compare the CT examinations with the PET-CT, you much better see these metastatic osteoplastic bone metastasis of prostate cancer. And until now, state of the art was fluorating choline. And nowadays, the new kid on the block is the gallium-68 PSMA PET-CT, and the bars look quite the same. But let's have a look to the PSA level. For example, at PSA recurrence of 0.5 to 1 nanogram, the detection rate is already 72%, whereas with the fluorocholine, it's only 36. Therefore, with the PSMA, there's a much higher detection rate in recurrent tumor, and in suspected prostate cancer recurrence, the optimal PSA cutoff is 0.8 nanogram per milliliter, which is a very low level. So this is the future of the detection of nodal and distal metastases. However, as we all know, histology is key. Why? Because it's everywhere. It's in the initial diagnosis, it's in the staging, and it is in the therapeutic decision-making. But how can we get the histology? Of course, we get the histology by the truss-guided biopsy. But it is known that in truss-guided biopsy, about 30 to 40% of cancers are missed, or the biopsy just hit the low-grade tumor or the low-grade part of the tumor, and the answer from urology initially was, oh, let's increase the number of biopsies. However, it has been shown that there is no real improvement. Instead, there's an increase in hospitalization, fourfold increase in hospitalization due to increased number of cores due to complications. Roughly, we have to deal with 2% infectious complications, 2% rectal bleeding, or 2% urinary retention. And there are areas which are difficult for transrectal guided biopsy. These are the ventral part of the prostate, the apex, and the far lateral part of the prostate. Why do I mention this? Because as radiologists, we see much more prostate cancer in these areas than in the areas which are written in the textbook, because these areas are hit by the urologists, and if the biopsy is negative and the PSA is still increasing, then the patient is sent to MR imaging, and then we see these prostate cancer in the so-called atypical locations. What's about MR-guided biopsy? If we see the lesion, we can hit the lesion. But how good are we? False negative results mainly occur in enlarged prostates, which is obvious, very small lesions, and also due to the displacement of the organ. The prostate is not a stiff organ, as it was mentioned. It's a soft organ. You can see this displacement. And Caroline Herx from Nijmegen, which is a perfect center, calculated that we have to deal with about 8% of false negative findings, even with MR-guided biopsy. So in case when we have a patient with a Pirates 4 or 5, and the biopsy is negative, then we recall the patient for an additional biopsy. But there are other options. What do we need? We need a sensitive and anatomically precise modality like the MR, and we need something which is fast, real-time, affordable, and has the option to add to the targeted biopsy a systematic biopsy of the prostate, and this can be done by MR ultrasound fusion biopsy. For example, like in this case, you see a very small prostate cancer on T2 as well as on the diffusion-weighted imaging, which is difficult to see on the ultrasound examination. And this is the combined MR ultrasound fusion. You see the lesion much better on the MR. With MR ultrasound fusion, the localization on MR is improved. You propagate the needle, retract the needle to avoid any displacement, and then you shoot and hit the lesion. And these are the data from our department. Roughly, we're doing 50 MR-guided biopsies a year, and during recent years, there's a significant increase in the numbers of MR ultrasound-guided biopsies because it's much easier and the results are really good. So let me compare the different techniques. This is not a scientific comparison. I describe the different techniques like this. This is truss-guided biopsy. This is cognitive biopsy. This is the one-modality biopsy, and this is a two-modality biopsy. So you can make your own decision. So, and now, of course, we should think about what's about to perform an MR examination before the first biopsy. But how would we read these two cases? Both patients don't had a biopsy before. I would say this is a Pirates 3. It looks like chronic prostatitis, and this looks like prostate cancer. However, finally, this was cancer, and this was prostatitis. What I would like to say, this is a challenge, because in the pre-biopsy scenario, we may have problems with MR imaging. And there are a lot of con arguments, mainly from the urologist part. False negative clinical significant lesions were identified in about 20% of the cases, mainly in the anterior part of the prostate. Sensitivity and specificity of MRI appear insufficient to avoid truss-guided biopsy. And let's have a look across the border. The Canadian guidelines describe multiparametric MRI followed by truss-guided biopsy should not be considered the standard of care because there is a poor quality of evidence, and that is true. And in patients with prior negative truss-guided biopsy, MRI may be considered. That means we, as radiologists, we need to have more and strong arguments. And just last year, Anwar Padani from London has published a perfect editorial concerning MRI before the first biopsy, questioning, has the time come? And he collected the following data. He said multiparametric MRI detects more significant cancer than truss-guided biopsy. MR-guided biopsy detects more significant and fewer non-significant, which is also a name of prostate cancer. MR ultrasound fusion biopsy detects 30% more high-risk cancer and 70% fewer low-risk prostate cancer versus trust-guided biopsy. And he concluded, yes, it is time to talk between urology and radiology. However, this sounds a little bit like an offense who said, let's get the football and win the game. However, as you know, every offense has to face a defense. And you can easily see that this is a urologist and concerning the dress. And there, a few months later, there is another editorial in European Urology entitled, Should Pre-Biopsy Multiparametric MRI be offered to all biopsy-naive men? And they concluded that the results may not be reproducible because the data mainly are from high referral centers. That's true. No agreement on acceptable rate on missed clinical significant cancers, but this is the same situation in urology. Long-term impact on multiparametric MRI and patient outcome is unclear. And finally, they say there might be a subgroup of patients, and these are the patients with previous trust-guided biopsy, which is negative, and an increasing PSA value. This was yesterday. Today, I would like to present you this extremely interesting study from Great Britain. This was published or presented by Hashim Ahmed, and he gave me his slides. He presented these data at this year's ASCO. This is a breathtaking study, believe it or not. They included 576 patients, and all these patients got a pre-biopsy MR, and then they got a biopsy of the prostate under general anesthesia. And I'm very happy not to be part of this study as a patient. They performed a template biopsy of the prostate, more than 50 biopsies, template, so perineal biopsies. This is the gold standard. The whole prostate was biopsied, and then another urologist performed a 12-needle trust-guided biopsy. So around 70 biopsy of the prostate. So be happy that you were not involved in this study. However, the results are the sensitivity detection of clinical significant cancer is much better on multiparametric MRI compared to trust-guided biopsy, and the negative predictive values are also better for MRI. However, the authors also ask, if multiparametric MRI were used as a triage test, what types of clinical significant cancers would be missed? And they said clinical significant cancer is a Gleason score 4+3, or any cancer with a cancer length of more than 6 millimeters. Look, clinical significant cancer may have been missed in 17 cases versus 119 cases in trust-guided biopsy. There are only 3+3 or 3+4 cancers missed by MRI, but no one of the more aggressive tumors. And therefore, the authors concluded that the high sensitivity and negative predictive value of multiparametric MRI can be used to avoid unnecessary biopsies. However, due to the low specificity and positive predictive value in suspicious lesions, still biopsy is needed. This brings me to the second last topic. This is image-guided therapy. And I include active surveillance and focal therapy into this chapter, because active surveillance has some challenges. Patient selection for active surveillance is not optimal. 30% is a dropout rate in the first 2.5 years, not because the man doesn't want to have any more active surveillance, because there is a significant proportion of histological reclassification. Reclassification means upgrading, and of course, active surveillance strategies vary significantly among the centers. An MRI might be helpful in active surveillance, like in this patient. This patient had a small prostate cancer, Gleason 3+3, and he was a candidate for active surveillance. These are diffusion and the contrast-enhanced examinations. However, what's going on there? Some more slides up, there is a much bigger prostate cancer, which was not hit and was not detected by the trust-guided biopsy. So for sure, this is no candidate for active surveillance. This is a candidate for radical prostatectomy. Or in this patient, in December 2011, we detected a small prostate cancer on the left-hand side, Gleason 3+3. The patient wants to have active surveillance. You see the diffusion-weighted image. And 3.5 years later, he had an increase of PSA, and instead of a rebiopsy, he wants to have an MR. This lesion, I don't know if it's really getting bigger, but there is more diffusion restriction indicating to be more aggressive. And the other lesion, which we didn't name in 2011, becomes more prominent, more larger, and more diffusion restriction. So the decision was made to have radical prostatectomy, and finally it was a Gleason 4+3 and 3+4. So the role of MRI in active surveillance can be described as follows. MRI is helpful in ruling out patients for active surveillance. If we see a positive lesion on MRI, 1 out of 2 or 3 patients will be no longer a candidate for active surveillance. Multiparametric MRI can be used to identify candidates for active surveillance and to monitor patients on active surveillance. And MRI improves identification of patients eligible for active surveillance. And please note, these are no radiological publications, these are all urological publications. What's about focal therapy? In many other organs, organ-preserving surgery or focal ablation is standard of care, but it does not the case in the prostate. Why? Yes, we still know prostate cancer is multifocal in more than 80% of the cases. But up to now, we think and we know that the extracapsular extension and the distant metastasis are mainly caused by the dominant intraprostatic lesion, the so-called index lesion. So this might be the focus for focal therapy, and there are different options like HIFU, irreversible electroporation, cryotherapy, or photodynamic therapy. In Berlin, we are performing the irreversible electroporation, or you can use something else, but the imaging is the key. We use MR ultrasound fusion for proper identification of the lesion, and then we place 3 to 4 needles around the index lesion, and this is shown not only on the transverse plane with MR and ultrasound, but also on the longitudinal slide, so to have the most appropriate location of the needles around the index lesion in the prostate. And for example, contrast-enhanced ultrasound is very helpful in the evaluation of the therapeutic result. This is a prostate cancer in the ventral part of the prostate, well vascularized. This is the patient under treatment, MR, and with the placement of the needles around the tumor on the transverse and the sagittal plane. And this is already 24 hours after the treatment, and you see a complete devascularization of the tumor area on the transverse as well as on the sagittal plane. But still, as in many places of oncologic medicine, the challenge is genetic polymorphism. And one piece of the puzzle might be, as we all know nowadays, is big data, and in radiology, this is radiomics. Radiomics offers a radiologist an expanded view by extraction of quantitative features as a biomarker. This is intensity, this is shape, and this is texture, and many more, like T1 and T2 mapping, MR elastography, or fracture analysis. T1 and T2 mapping gives us real information about the T1 and T2 relaxation times of the tumor. And this is not a T2-weighted MR imaging, this is MR elastography, giving us information about the elasticity of the organ. You can see the transitional zone in the peripheral zone in the normal prostate. Or another case is fractional analysis, which analyzes the homogeneity of the vessels in the tumor, where it's more heterogeneous in more aggressive tumors versus low-grade tumors. So these are all data which are in our images. And concerning big data, there are two different opinions. The pro opinion is, like Jim Thrall has mentioned in his remarkable annual oration presentation at last year's RSNA, he said, huge amount of data are hibernating in our images. Let's turn dump data into knowledge. However, another group says, if you have huge amount of data, these may lead us to making systematic error with higher precision. So again, you can see this is still a yin and yang story. So finally, how should I conclude my presentation on imaging of the prostate? And I don't want to answer this question from the radiological point of view. I try to answer this question from the urology point of view by citing 3 publications which are just published or will be published in European urology this year. One paper is dealing with the role of magnetic resonance imaging, focusing on what really matters, and they said, we need to have a targeted screening and we need to include imaging and image-guided therapy in this strategy. Another paper from urologists are dealing with the problem what to do with the non-significant cancer. The problem is how to avoid to see these cancers. And they said we need to have a personalized screening together with the adoption of multiparametric imaging before the biopsy. However, there's another journal, a publication, which is a little bit more critical. They say, concerning to dismiss trust-guided biopsy, they say, we have problems with multiparametric MRI and MR-guided biopsy. We need to have a concept of individualized precision biopsy, but this includes imaging as well. And therefore, I'd like to conclude that the current trend in prostate cancer is clearly away from a one-size-fits-all approach towards more individualized strategies. Imaging will play an important role in the area of precision medicine, and innovations in imaging of the prostate are tightly linked to more precise diagnosis and the ability for better selection of therapy. And with this last slide, which shows one of the Charite campus in Berlin next to the House of Parliament, I'd like to thank you for your attention. Thank you.